coexisting pain problems and psychiatric symptoms. So unfortunately, some of the people we work with are already developmentally disabled. They're going to have psychiatric histories and or current psychiatric problems, and they're going to develop pain problems, or the pain problems they already had are going to get worse. And so in this case, we're faced with the necessity to come up with effective management strategies for both the psychiatric difficulties and the pain problems. And we'll give away the conclusion a little bit by saying that a main principle of doing this successfully is that both problems, the pain problem and the psychiatric difficulties, have to be managed simultaneously. So sometimes people take the approach that we need to manage the psychiatric symptoms first, and somehow we can put the pain problem off and start managing it or addressing it once the psychiatric difficulties are under better management. And then other people kind of make the opposite and complementary mistake where it's thought that we can start by managing the pain difficulties, and then when the pain problems are under better control, then we can move on to try to address the psychiatric symptoms as well. But the problem with this approach is that each type of symptom is likely to worsen the other. So pain symptoms are certainly likely to intensify the psychiatric difficulties that people with psychological problems already have. And in the same way, psychological difficulties are very likely to worsen the pain problems that somebody may be developing. So pain problems, psychiatric difficulties reinforce each other, creating a kind of a vicious positive cycle. And the effective way to intervene with that is to work and start out working with both simultaneously. But that's a complicated process. As we get into it, we'll see what some of the important steps are. So we need to think about the same order or cascade of interventions for people who have developmental disability, pain, and psychiatric difficulties as we thought of for people with developmental disability that had pain problems but no psychiatric symptoms. We would start with behavioral interventions as appropriate. We would also then think about non-pharmacologic interventions and comfort measures, as the other Dr. Shrigovoff brilliantly explained. And then as a last resort, we would think about pain medications. Now when I say last resort, we're not talking about avoid if at all possible, because remember our overall goal is effective pain management. And effective pain management can and frequently does include pain medications. But this is just the order in which these interventions should be considered. So when we're considering behavioral interventions, remember that we're going to do a behavioral analysis of the pain symptoms. We're going to identify a set of behaviors or target behaviors that we're going to work with the patient on changing or making more adaptive or learning skills or improving. And then we're going to work as a staff to make sure that we're reinforcing the kinds of changes that we think would be helpful. For the non-pharmacological strategy, we're going to be using comfort-enhancing measures, comfort boxes, and so forth. Just as for developmentally disabled people who have pain symptoms but without psychiatric difficulties, even those who have psychiatric difficulties can benefit from the non-pharmacologic measures as well. And we are going to look at pain medications that we might use. Think about things like regular schedule versus PRN, and as we were discussing prior to the break, try to make therapeutic use of side effects of medications when at all possible. So the kinds of observations that we need to do in this case are even more complicated than the ones we were doing when there was just a pain problem, because now we're not only looking at all the details of the pain complaints and pain behaviors, statements, behaviors, physiological evidence, interactional evidence, emotional aspects of the pain problem, but we're also, in addition, looking for the psychiatric symptomatology, whether it's anxiety, depression, irritability, psychotic symptoms. And the general principle is that we have to try to evaluate, assess, and observe and monitor both kinds of symptoms together simultaneously. And one of the things that we are looking at in the course of doing that general approach is to see if the pain symptoms and the psychiatric symptoms seem to have some connection to each other. In other words, do the psychiatric symptoms get worse when the pain is worse, or looking at it the other way, does the pain get worse when the person is having an exacerbation of psychiatric symptoms? If we observe those kinds of connections, then we can hypothesize that an important part of this person's pain problem can be psychiatric symptoms, and the psychiatric symptoms continue to contribute to the problem with pain. And in a few minutes, we'll go over some specific examples of that and ways that that can happen. But because of this added complexity, we could easily see that having a plan D in mind and having a plan C in mind, which we already had to do anyway, even when there weren't psychiatric symptoms present, now we have to be even more ready to make adjustments in the treatment plan for pain and for the psychiatric symptoms. So of course, we're going to be observing how is the pain expressed. Just like when we were talking about for a developmentally disabled person that doesn't have a psychiatric issue, we're looking at the details of the communication, experience, and expression of pain. And we're adding, does this expression vary with psychiatric symptoms? And do we see psychiatric symptoms like, for example, paranoid delusions or auditory hallucinations, or rapid fluctuations in mood, or mood disturbance like severe depression, or mania for that matter, or clinically significant anxiety? Do we see any of those things, and do those things appear to have any relationship with the episodes of pain complaints that we're seeing? And again, if yes, if the answer is yes, if when the person becomes more paranoid, for example, they develop stronger symptoms of pain, or when they seem to be responding to internal stimuli, or for example, hearing voices, they seem to have more pain, or when the mood is more depressed or irritable, they seem to have more symptoms of pain, then that's strong evidence that there may be a connection between the psychiatric symptoms and the pain. If we don't see a relationship like that, if we don't see a connection between, let's say, paranoia and pain, or auditory or visual hallucinations and pain, or mood disturbance or depression and pain, then we may be, in that situation, working with two separate problems that don't happen to relate to each other. In either case, it points up the importance of working with both simultaneously, because if the psychiatric symptoms and the pain symptoms are related, you must address the psychiatric symptoms in order to get as good a management in place of the pain symptoms as possible. If they're unrelated, then in addition to working effectively with the pain problem, you of course also have to work effectively with all of the other problems that the patient has. General principle of doing clinical work, and in this case that would apply to psychiatric symptoms. So the behavioral analysis of pain with a developmentally disabled person who also has a psychiatric history is similar in a number of ways to the behavioral analysis that we were looking at when the person didn't have psychiatric symptoms. So we want to look at how pain is expressed before, or I should say how the patient experiences pain in various circumstances. So for example, if they usually experience it during a particular activity, what comes first, the onset of the activity, the onset of the pain complaints? Do they experience it during a particular activity? What are the various parts of the body that may be involved? Do they experience pain following an activity? What are the residuals of that activity, let's say, that may be involved with pain symptoms? Are they suffering from chronic pain complaints? How are the pain complaints expressed in all of the different channels, verbal, vocal, emotional, interactional, behavioral, and physiological. And one additional thing that's helpful to look at is whether or not the pain complaints seem to be related to the schedule of psychiatric medications that they may be taking. So for example, if a person has a problem with psychosis, you have a developmentally disabled patient who has a pain problem and a history of paranoid schizophrenia, and they're being treated with antipsychotic medication for control of the primary psychotic symptoms, and suppose they're getting that medication, say, twice a day for argument's sake. Is the person observed just prior to the medication dose administration to be becoming more paranoid and simultaneously complaining of more pain? That's a strong hint that the psychiatric symptoms, in this case paranoia, are contributing to that individual's pain complaints. And managing the paranoia more effectively, maybe with a different schedule of medication or a different dose or a different type of antipsychotic medication, might also have some positive impacts on the pain problem. Similarly, if the person is having is being treated for an anxiety problem as well as pain issues, and when they have more anxiety, they seem to be complaining of more pain. And when they take anti-anxiety medications, the pain symptoms seem to decline as well. Again, that might argue for a close look at how are we managing this person's anxiety problems. Are we doing everything we can with the anti-anxiety or anxiolytic medication? Are we doing everything we can with behavioral treatments for anxiety? Because that may have a benefit for their pain symptoms as well. If we see that pain is experienced by somebody who has developmental disability and depression, and that the worse their depression gets, the worse their pain gets, we kind of expect this frequently to be the case because, as we talked about in the prior workshops, there seems to be a close connection between depression and pain. Some of the same neural pathways that seem to be involved in the experience and expression of depression problems are also involved in the experience and expression of pain problems. So if we're treating somebody who is developmentally disabled and we're treating them for pain and depression as well, and we see from our psychiatric observations of them that they seem to have some ongoing symptoms of depression. They're sad, periods of crying, they're not enjoying much, maybe they don't have much of an appetite, losing weight, not sleeping well, heaven forbid, maybe expressing some lethality, some ideas of hurting themselves or even hurting someone else. If we see persistence of depressive symptoms in somebody we're already treating for depression and we're also treating them for pain, we might be able to make the prediction that the pain problem is not going to respond as well to the pain management interventions that we're doing as if we weren't seeing that continuation of depression. And in that case, it's an argument for reevaluating our treatment of depression and making some changes in the treatment plan for depression, whether medication-related or therapy-related or activity-related, that would address the depression more effectively. Because in this particular case, and with this particular developmentally disabled patient, if we address the depression more effectively, we may address the pain symptoms more effectively. So frequently, when we look at the behavioral analysis of pain in people who have coexisting psychiatric symptoms and developmental disability, we would look to see if the pain is experienced with certain staff members. There are more pain complaints when it's the day shift or the evening shift, for example. When certain family members or visitors come, that the patient more likely to complain of pain. There's certain types of people with whom the patient seems to be experiencing and complaining of more pain. If we see these things, if we see that there are certain staff members with whom the patient experiences higher levels of pain complaints, we may want to evaluate which staff members is the patient complaining of pain more when they're on. And is that because, for example, on the one hand, they're getting some positive reinforcement for pain complaints, maybe accidental positive reinforcement, by those staff members, or do those staff members have particular characteristics that to this particular patient interact with that person's psychiatric disturbance to make the psychiatric disturbance worse and then lead, to increased pain complaints. So, for example, if a developmentally disabled person with psychiatric history and pain complaints has been in the past, unfortunately, traumatized by somebody, and now the evening shift comes on, and there are people working on the evening shift who look like the person who inflicted the trauma or in some way interact, maybe with voice tone, accidentally like the person who inflicted the trauma, that may be a clue that when the pain complaints get worse with certain types of people, certain types of staff members, that there is an unaddressed or under-addressed problem of a psychiatric nature that needs to be looked at. In this case, maybe a component of PTSD. When certain family members come in and the patient complains more of pain than at other times, one explanation for this can be that those particular family members may, in some cases, accidentally be reinforcing pain complaints. Or in some cases, for example, when there's litigation about an accident and the patient is the plaintiff, but the family members are involved, family members may overtly be encouraging the patient to complain of pain because they think it will look better in the courtroom and get a bigger lawsuit victory or settlement. So we have to think about when family or visitors seem to evoke pain complaints, whether factors like that are operating, versus if somebody has long-term psychological issues with their family, and do the pain complaints express those kinds of psychological issues. So when we see that pattern, family members or visitors evoking more pain complaints, one of the things that we should think about in terms of an assessment is whether or not there are issues present that are evoked by those people. And similarly with certain types of people, tall people, particular gender, people who have deep voices, name your characteristic. If we can identify a certain characteristic of person with whom the patient interacts that seems to evoke more pain complaints, that is a strong hint that there are underlying psychological issues that either we haven't addressed or maybe we're not addressing adequately, and those in turn are more likely to evoke an increase in pain complaints. Similar comments could be made about observing where the patient experiences pain, or is it experienced during certain activities, certain physical activities. Sometimes those locations or those activities, if we think about them, may be clues to the kind of psychological issues that the patient may be wrestling with, but expressing through pain symptoms. So these are psychological issues that can frequently be associated with increased pain complaints in developmentally disabled patients. Anxiety symptoms. When a person is anxious, they are sort of hyperreactive and hypervigilant, and one of the things that they are hyperreactive to and hypervigilant about is experienced pain. Depression symptoms. We've talked a bit now about how depression and pain to some extent seem to operate in the same neural pathways and processes, and therefore depression makes a person more likely to experience pain, and pain, on the other hand, predisposes a person to an additional risk of depression. If a person is agitated, they have the same kind of hyperreactivity and internal focus that someone who is anxious may have, and they may be more disposed to feeling pain. And a person, a developmentally disabled person with pain problems and psychosis, particularly if the psychosis has a paranoid component, will frequently focus on pain as a confirmation of the paranoid delusions. So they may have a delusion that somebody acting at a distance is doing something bad, wrong, or evil, and that's causing them problems, and they have some actual pain, and they incorporate that into the paranoid delusions and regard the pain as a confirmation of their delusional idea of being persecuted at a distance. So these four psychological issues and syndromes can be associated with increased pain complaints And in a corollary way, if we do treatment of these problems that is as adequate as possible, we might be likely to reduce the patient's vulnerability to ongoing pain symptoms or to get the pain problem to its best possible place. So when we develop behavior plans for this patient population, we're developing behavior plans for both the pain problem and the psychiatric issue. And the plan should address both the pain and the psychiatric problems. And just like what was said previously about behavior plans, they have to be workable for everybody involved. So all of the disciplines involved with the person, psychiatrists, psychologists, nurses, social workers, therapy aides, physical therapists, rehabilitation therapists, and everybody else with whom the patient interacts has to understand the plan, the behavior plan, has to have had an opportunity to provide input into it. Everybody has to be on the same page that this is a good idea to do, and everybody has to have the motivation, the skill, and the time to carry it out. So this is really a team activity that crosses disciplines. All staff have to implement a behavioral plan for managing the pain and psychiatric symptoms. If we have a treatment unit that has 10 staff members on it, and 9 of those staff members are implementing the behavior plan, and 1 is doing something else, it's an absolute guarantee that the behavior plan will fail. This is the peculiar vulnerability and some might say weakness of behavior plans. If we're treating somebody with a pharmacological agent, it just takes 1 person to administer the medication. But if we're treating somebody with a behavior plan, it takes everybody on the treatment team to consistently implement the plan if it's going to have any chance to work. So behavior plans are easily disrupted, and therefore we have to proceed with frequent evaluation of how the behavior plan is working to see if there are any disruptions. And do any of those disruptions relate to somebody on the staff is not on board with it? Or do they relate to other complicated factors that we've been discussing? And the addition of the psychiatric symptoms to the pain problem in a developmentally disabled person is another complexifying factor, if we want to put it that way. So never a good idea to make a behavior plan for managing pain and psychiatric problems and then let it go on autopilot for a while. Always more monitoring is better than less monitoring in these circumstances. So we'll talk about a couple of sample behavior plans for 2 examples of coexisting psychiatric symptoms and pain problems with a developmentally disabled patient. So a sample behavior plan for pain and psychosis. For the pain part of the problem, we've done our MESIP evaluation and we did our behavioral analysis of pain behavior, and we see that we have a developmentally disabled patient who has a pain problem and is having an ongoing problem with psychotic symptoms. And we find that the person is shouting out frequently all day long when in pain. So the behavioral part of the plan for the pain-related behavior would be to try to help the patient learn to express pain complaints at a normal or better or more adaptive voice volume rather than shouting out, would be to give positive reinforcement, praise, empathy, support when the person is able to complain of pain in a more adaptive communicative style. And as treatment goes along, work on skill acquisition. So when the pain is adequately addressed to the extent possible, whatever amount is left, can the patient learn a relaxation technique that's appropriate, or can they learn self-distracting skills, or can they learn to make some positive self-statements like I can get through this to help manage the distress related to the pain. For the psychosis part of the behavioral management plan, we would have We would have, of course, antipsychotic medication that would be a given in this case if medically feasible. But we would also have reality orientation. People who have psychotic symptoms need more frequent help, support, and reminders of what is going on versus what may not be. People who are psychotic need more directive guidance from staff than does the non-psychotic person. And over time, the patient may be able to learn some skills if they're even at the maximum benefit of treatment. If they have some ongoing residual internal stimuli like delusions or hallucinations, we might teach some skills to distract from those perceptions and lines of thinking when they do occur. So in this plan, we've got elements that address both important components of the pain and the important components of the patient's psychiatric difficulty. Now let's say we're working with a developmentally disabled person who has pain and depression. And the component of the behavior plan, for example, for the pain would be arrived at after we do our MESIP analysis, and we do a behavioral pain analysis. And we see that we have a developmentally disabled person who is having some ongoing problem with depression, and they seem to be increasing in their pain complaints. And we observe that what happens is that a staff member comes over and does an assessment of the symptoms and talks to the person in a solicitous and empathic manner about what's going on. We know about depression that when a person is depressed, they frequently need more empathy and support. And so our behavioral analysis seems to indicate that a part of the function here is to get more empathy and support. Remember, all behavior is a response, and all behavior has a function. So in this patient, the response is to not only the pain, but perhaps also a sense of loneliness and a need for support. And the function that the pain complaints are having is to get that support. So we would like to, in this case, change the way that the staff interact with the person so that they're interacting at a higher frequency, giving that needed empathy and support, even when the person is not complaining of pain, so that the connection between pain complaints and receiving empathy and support is not so strong. And when, as we were talking in the other example, when evaluations need to be done of pain complaints, they're done in an effective way, but they're not overly dramatic or overly supportive as compared to all the other interactions. And we would perhaps in this case also think about scheduling a time every day, a meeting that the patient gets to meet with a staff member and review what's happened with pain that day, so the patient has the feeling that every day someone's going to listen rather than really not knowing and having to cry out in pain to be able to depend on getting attention. For the depression part of the problem, as I mentioned, you would need increased empathy and support. Many people who are depressed with developmental disability and pain problems need help in scheduling adaptive daily activities. A certain level of activity and interaction when medically feasible is important to support the person's mood. Unfortunately, when people get depressed, they tend to withdraw and become underactive, and that worsens the depression. So helping the patient maintain an adaptive and productive schedule on a daily basis, which can help with the person's depressive mood, and an increase in empathic support also can be helpful with depression. So those are examples, two problems, psychosis and depression with pain in a developmentally disabled person, and you can see that the behavioral treatment plan would include elements to address both the pain problem and the depression. So sometimes we work with developmentally disabled people who have problems with pain and also anxiety. And these two frequently go together because, frankly, who doesn't get anxious when they're in pain? But if a person already has a pre-existing psychiatric problem with anxiety, that's going to be worsened by pain. And again, the internal focus of hypervigilance and hyperreactivity that tends to go along with anxiety tends to worsen pain perceptions. So in this case, a part of our plan, in many cases, would include a relaxation procedure. The relaxation procedure could be a form of progressive muscle relaxation. It could be guided imagery. It could be a relaxed breathing. It could be a distracting activity like listening to music. The particular form of the relaxation procedure would have to be tailored to the needs of the individual person that you're working with. But many developmentally disabled people can learn one or another forms of relaxation procedures, and they can be helpful. Distraction or developing skills at distracting oneself from pain, particularly when anxious, can be a useful intervention, and that can involve activity, or it can involve making certain kinds of self-statements or using cognitive behavioral techniques like thought stopping. Imagine you're seeing a stop sign, 8 sides, red sign, white letters, stop, and then think about something else. And then for anxiety, particularly we find that when it's medically feasible, exercise is very helpful because some of the same internal physiological mechanisms that are involved in increased anxiety symptoms will get fatigued, so to speak, by exercise and then be less likely to contribute to anxiety problems. Many times people who have developmental disability, pain problems, and anxiety, when they do express pain, it's going to be of the sudden crying out form of pain expression. So in this particular case, as feasible, working on skills to express pain in a more adaptive way, again, scheduling perhaps a daily pain monitoring session, and positive reinforcement when pain is expressed appropriately would be helpful. So before instituting a behavior plan, we should examine the environmental contributions or causes of both pain and psychiatric symptoms. So why are we emphasizing the E in the MESIP here now? What's special about that E? Well, if you think about it, the medical factor, the sensory factor, the interactional factor, and the psychiatric factor all involve the patient. But the E factor, the environmental factor, is just where that patient happens to reside, live, or be. So in a way, if we can find contributory environmental factors that are contributing to problems with pain or psychological difficulties and alter them, we are doing a very relatively less intrusive intervention than if we start mucking about with the patient's medical treatment, sensory processes, interactions, or psychiatric status. So some problems are solvable with relatively simple environmental interventions, I should say. So for example, we had a 60-year-old male patient post-stroke with associated right-sided pain, hemiplegia, and mild intellectual disability. And he was in a facility, and when came time for lunch, the patients would go into a lunchroom and sit at tables and be served lunch, and he was right in the traffic pattern. So all of the staff coming back and forth into and out of the kitchen had to walk right by this person carrying trays of food. And when he was in pain, which happened unfortunately fairly frequently because it's kind of a common after effect of stroke, he would reach out and grab at the staff inappropriately. So this was obviously a very disruptive behavior, very disturbing for staff. It turned out that in addition to reviewing his pain management treatment, which needed a medication change, it was possible to have him sit on the other side of the table where he was not in the traffic pattern and couldn't really grab staff inappropriately. So here a simple environmental intervention probably saved a lot of work and a lot more intrusive interventions with the person and basically solved the problem at that time and place for that person of grabbing at staff inappropriately. So we include the same basic components that were included for pain management approaches. We would also use those for pain management in people who also have psychiatric symptoms in the context of developmental disability. We've got the same set of techniques from which we're going to draw. The difference, though, is that some of these techniques may not be appropriate for people with certain sets of psychiatric difficulties. So, for example, we were talking about relaxation procedures. Some people who are paranoid, some developmentally disabled patients who are paranoid, and as a matter of fact, this is even true of non-developmentally disabled patients who are paranoid, do extremely poorly with relaxation techniques. It puts them, because they're paranoid, in a position that they feel too helpless in. So we have to factor in what is the psychiatric difficulty that the person is having and modify the pain problem-related intervention so that we don't accidentally make the psychiatric symptoms worse. So relaxation training sometimes needs to be delayed until a person's paranoia, if they have that symptom, is under better control. There's a kind of relaxation where you focus on internal physiological sensations and slowing the breathing down. For some people, that's uncomfortable. For somebody that's highly anxious, that can be uncomfortable. Restrictions on breathing rate for an anxious person can sometimes make them more anxious. So when we think about the standard set, let's say, of pain management interventions of a behavioral sort that we do, we have to put them through the filter of what are the present psychiatric difficulties and which ones might be likely to work best with somebody with this psychiatric difficulty. On the other hand, which ones might we not want to pick because of the nature of this particular psychiatric difficulty.
So the non-pharmacological strategies that we're going to spend some time talking about individually takes into account the person has pain, they have a coexisting developmental disability of some kind, and they have psychiatric symptoms. So comfort boxes, which were mentioned before, is just an accumulation of items that that individual with his or her special features is going to be able to derive some comfort from. And people get comfort from different experiences. Some people like to listen to music. Some people would prefer to have a nice cup of tea. Some people like to take a shower, although it probably happens a little less often than we would prefer with some of our individuals. There are a lot of experiences that can be pretty helpful. Smells, olfactory experiences are part of the most primitive part of our brain. That part of the brain develops with the most basic aspects of who we are as human beings. So something that deals with a smell is going to be associated with a memory more easily than anything else. It's something that you hear, or something that you see, or something that you taste, or something that you have tactile sensations about. So sometimes people can be very comforted by a certain smell, an aroma, and that's why aromatherapy can be highly effective. And there's a number of ways to do that. Everybody has something that they really like to smell. Some people are very happy about smelling bananas or cinnamon, very soothing, vanilla, lilac. So everybody has something that can help them to concentrate on their wonderful experiences and distract them from psychiatric symptomatology and pain. And that can go along with their sensory experiences. Your comfort box can have items in it, but your sensory experiences will deal with where is that person's strength. Do they like to look at things? We recently had a young woman who, she's just turned 30, she just has to touch things. It's not that she gets a particular joy out of what she is touching. She gets joy out of touching. And she doesn't touch people, she touches things. So she'll walk by a plant and she'll touch the leaf. She'll walk by a stack of paper cups and she'll touch a cup. And that actually helps her. She's a very tactile-oriented person, and she gets a great deal of satisfaction and joy out of touching things. And actually, it works out that she's not into touching people, because that could be really a problem, especially in her work site. She works in a sheltered workshop, and if she liked to touch everybody, that could be a problem. So it actually works out. So bending to her strengths of touching things addresses the sensory experiences. So when she has pain, she can, and her psychiatric symptoms happens to be trauma and self-abuse, some SIB, some self-abuse, injurious behavior. She needs to be able to focus on a sensory experience so she can get past that, the pain surge or the self-injurious behavior urge. Distraction's always good, and there's a number of different ways to distract. The other fabulous Dr. Triglav mentioned thought stopping, and there's lots of different ways to do thought stopping. Some people are very focused on visual imagery, so you actually can envision a stop sign. The color is good, the texture imaginary, it's shiny, that's good. The word across it, if they're reading, is good, because big, it's short, it's simple, the contrast is high between the background and the foreground, and that kind of distraction can be very helpful. Sometimes people will take a rubber band and they'll put it around, a loose rubber band, they'll put it around their wrist, and for thought stopping, they'll give themselves a snap. Not a huge, very painful experience, but just something to say, oh, pay attention to that instead of paying attention to something else. And it gives them control, and it gives a sense of a mastery that's very easy. You don't have to learn a lot in order to have a rubber band tightening around you or giving you a snap. Biofeedback, as I mentioned before, is very helpful for a wide range of people who have developmental disabilities. Ice and heat, depending on the type of pain and how it responds and at what time it's very responsive. Some people really need ice first thing in the morning for certain muscle spasms, and they really need heat on exactly the same areas around 4 o'clock, 5 o'clock in the afternoon to try to ease out some of the knots that have developed in their muscles. Acupuncture and acupressure, like I said before, acupuncture not quite as likely, but acupressure can be very useful, as can massage, self-massage, a massage therapist who specializes in people who have developmental disabilities, or self-massage with the Theracane, where you're using something. And we saw at the mall these, they have the little spa, it wasn't the mall, but the airport. They had a little spa at the airport, and they sold these small, you just stick your fingers in them, and they were plastic areas. And so you could just fit it onto your hand and give yourself a massage, just as a general sensation, but also to get into the trigger point. Ultrasound I mentioned, and these things can be very helpful for people who have psychiatric symptoms, because they can put themselves in the situation where they're feeling the heat and they're concentrating on the heat, and they have some control over the situation. A lot of people who have psychiatric symptoms don't feel like they're in control. They feel like they're burdened, or these things just happen to them and they don't know what to do about them. So a lot of these non-pharmacological strategies that we're talking about today have the capability, when somebody has pain and a developmental disability and a psychiatric symptom, to really give them a sense of control, and that'll help them in all three of those areas. The TENS, it's actually pretty helpful for people who have psychiatric symptoms as well as the pain and the developmental disability, because it can get past some of the tactile sensitivities that people frequently have, and it's very good for pain management, and the person has complete control over how much of the tapping experience they're going to have and how long they're going to keep the electrodes on. The only time we have found that to be not a very useful strategy, and this is for somebody who has muscle spasms, and not from cerebral palsy, but from an injury, is when the person had a delusional experience, and the delusion was more mechanical in nature. And we found that that's, of course, a challenge to somebody who has that point of view. The same thing with vibration if they're using a vibrator. Cushioning and splinting, very comforting, holding themselves in a particular position, splinting so something is tighter and almost swaddled can be very helpful, especially if the developmental disability and the psychiatric symptoms deal with the parasympathetic nervous system, because those are calming strategies. Visualization and guided imagery, we found that to be actually helpful with people who have psychosis as well, except when, as the spectacular Dr. Triggerboff mentioned, if it's a suspicion of persecutory paranoid delusion. That can be very difficult, because when you're trying to relax, you're making yourself more vulnerable. And if you're trying to visualize something that's going to be very soothing, if you're a suspicious person, you're not going to go there. It just makes you feel too vulnerable to the world. Art and journaling, this is a good thing for people who have psychiatric symptoms, especially if they are on the side of personality disorders or disruptions, strong traits of personality features that are problematic, and it can help. One of the people we were consulting with just a couple of weeks ago, she has a lot of difficulty hearing certain words. They're very disturbing to her, and everybody has pet peeves, things that really bother you. You don't like to hear things. Well, she cannot stand the words moist and blouse. Those two words, for some reason, really send her off. So you don't have control over what words other people are going to use, and sometimes people use the words moist and blouse, not because they're trying to bother you, but because those are perfectly reasonable words to use in a conversation. And so her journaling around that has been very helpful. When she hears those words, and there's a number of them, those are just the two I can think of off the top of my head, she's supposed to sit down, and she does journal fairly well. She's supposed to sit down and write. How does she feel about that? And she's not, it's not encouraged for her to write, I don't know, or it's bad. So she had to be a more descriptive in her journal, and she was doing quite well with it, and it really helped her to do that. And of course, we mentioned the breathing exercises before. The only difficulty we've routinely seen with breathing exercises is people who have a high spasticity level from cerebral palsy. They're not able to deep breathe as deeply as we'd like them to, and they can't hold it for as long. But any depth to the breathing is very helpful. So that's the non-pharmacologic. The pharmacologic intervention, now again we're talking about the triple whammy of you have a developmental disability, you have pain, and you have a psychiatric symptom. So let's talk about using antidepressants. Because depressive reactions do amplify pain sensations, that is a neurological as well as a psychological fact. Antidepressants can be extremely helpful. You're treating the depression while you are addressing those pain symptoms. And when you treat the depression, your sensitivity, your serotonin receptors, your resilience in general, and your inability to cope because of your depressive symptoms, all of that is ameliorated by an antidepressant. So you might be able to get a lot of bang for your buck out of that. And the only caution that we need to put into place is that there are a few antidepressants that people can get a buzz off of. They can get a little bit of a sensation that is addictive. And so we try to avoid those. And it's not very common, but it's something to keep in mind, because we're trying to improve the situation. We're not trying to add a whole other layer of complexity to it. Anticonvulsants, as we mentioned before, there's a few of them that can be used. The most strategic one is gabapentin, Neurontin. It decreases neurologic hypersensitivity that some pain messages are composed of, and it normalizes their mood state. So sometimes people who are in pain are disrupted, and even if they have no diagnosis of bipolar disorder or schizoaffective bipolar, they can be destabilized to the point where they're having a lot of difficulty with their mood because of their pain. And I'm sure you've all seen people who are in pain. If you've ever had a headache, you're not going to be the gloriously fascinating and lovable person that you would normally be because you're in pain. So you're going to be more irritable or more withdrawn, or you're not going to have such a wonderful, jolly time. So anticonvulsants that are mood stabilizers also will take care of that. It'll help the person's mood be buoyed up a little bit. The downside of that is that when somebody is changing an anticonvulsant from one to the other, or they're coming off their anticonvulsants and they're titrating down, that also can be destabilizing to the mood. Most of the anticonvulsants have slightly different neural pathways. That's why you switch from one to the other. One stops working or it's not working completely enough, and so you need to have another pathway addressed. And that mood might become unstable as a result of it. Something to keep in mind when somebody is trying to get their mood and pain addressed. Along the lines of more non-opioids to deal with pain are anti-anxiety medications. And this is not entirely different from when you're dealing with people who have pain and developmental disabilities. But adding a psychiatric symptom of anxiety is important to keep in mind. Some people who have schizophrenia, schizoaffective disorder, certainly obsessive-compulsive disorder and post-traumatic stress disorder, because they are anxiety disorders, as well as generalized anxiety disorders, they probably need ongoing benzodiazepines to manage those anxiety episodes, or if they have a panic disorder. So the benzodiazepines would more likely be used in that. Now, the rules have changed a lot across the country for what do you do with benzodiazepines. A lot of insurance companies will insist that the clinician ask about dose reduction or just start dose reduction on a benzodiazepine, and that is very difficult. You have somebody who's anxious, and they're in pain, and they have a developmental disability, and they're on a benzodiazepine, and it happens to be managing their anxiety. And by law, by insurance, by money, by clinician preference, the dose is reduced. Even though it must be done slowly and it must be done carefully, it's a titration process that cannot be rushed. If you're taking somebody from, let's say, the most recent one I can think of is the woman we had who was for 17 years on Xanax. And because benzodiazepines have a tolerance feature to them, she had gotten all the way up to, and this is a little one, a little woman, she got all the way up to 4 milligrams of Xanax. This is a tremendous amount of Xanax, and she started out at like a 0.5 milligram a day, but over 17 years that's what it got up to. And it was determined that she needed to come down. So they took her from 4 milligrams to 3.75 milligrams, which is a very reasonable dose reduction. But whenever somebody is being reduced on their dose of a benzodiazepine, everybody needs to be aware, everybody, the individual and everybody who is involved in their care, needs to be aware that there's going to be several days where things are going to be pretty brutal. The person's anxiety will rebound, imaginatively enough, rebound anxiety. So if they were being treated with a benzodiazepine for anxiety, their anxiety is going to go up. And like for 3 days, they're going to have a very hard time. If you're prepared for that, then everybody knows it's just temporary and it'll settle down and the nervous system will get back on track. But if you're not prepared for that, everybody's going to be thinking, including the client, oh my God, I can't come off this stuff. I have to stay on it. So I need my 4 milligrams. There's no way I'm going to be able to live without it. So there's a preparatory feature to it when you're going to be reducing somebody on a benzodiazepine, and you leave them at that lower dose for like a month, and before you think about whether they need to have further reduction in the dose. You don't have that issue with benzodiazepines physiologically, but there is a psychological dependence on even non-benzodiazepines. For example, if you're taking Ambien, which is a non-benzodiazepine for sleep, the individual might become conditioned, classical conditioning, that in order to get a good night's sleep, they need this pill. And if they don't get the pill, they're not going to have a good night's sleep. So there has to be some education and some training about that. Many people who have a developmental disability and psychiatric symptoms may already be on an anti-anxiety medication. That's because it is extremely common that the psychiatric symptom is going to have some component of anxiety to it. So being on an anti-anxiety medication, as I'm sure you all know, is extremely common. So the medication or the dosage time might be changed to address pain symptoms, because it can be very effective if you bring down the anxiety. It brings down the tension, it brings down the stress, it increases the resilience the individual has. We like to teach people how to deal with their pain non-pharmacologically. Sometimes you need to have a multiply determined system in place to really make it work. These options for people who have developmental disabilities and they're trying to manage their pain are not different when they also have a psychiatric experience. Muscle relaxants, as I mentioned before, helps to relax their muscles, helps the fibers to glide along each other instead of snagging and spasming. So that can be a pain management routine. But keep in mind that some of the muscle relaxants have some pretty significant side effects. One of them is sedation. So you would like to give the muscle relaxant at a time of day when it would be okay for them to be sleepy. You give it to them at 8 o'clock in the morning before they go to work or before they go to program or before they have chores to do around the residence, and they're just exhausted and they just want to go to sleep. It creates a behavioral problem that doesn't really need to be there. Muscle problems typically happen later on in the day. When you get up in the morning, if you do certain stretches, you can manage with muscle pain. So muscle relaxants are better done later in the day, and the later you can do it might actually help with some sleep, so you can remove one medication from the regimen. Another side effect, though, of some muscle relaxants is visual hallucinations. That's happened on more than one person we've been called to do a consult on. So they think they're having the psychiatric symptom of hallucinations, and they really are having a hallucination, but it turns out to be a side effect from an entirely different source than a psychiatric disability. Over-the-counter meds, aspirin, ibuprofen, acetaminophen, these are all the same as they would be for somebody who did not have a psychiatric disorder. Opioids, as I mentioned before, not to be dismissed for people who have a developmental disability and a co-occurring psychiatric disorder, and they're trying to deal with pain. But the risk of dependence is elevated when you put a psychiatric symptom into place. And just to greatly abbreviate the explanation for that is that anybody who has a major mental illness, schizophrenia, schizoaffective disorder, bipolar disorder, major depression, doesn't really matter what it is, you have a major psychiatric problem. Your neurological system is going to respond to substances differently. There's a temporary pathway that's developed with people in the general population when a substance of abuse is ingested. And you know, if you've ever smoked cigarettes, how very difficult it is to remove nicotine from your body along that temporary pathway. It's a neural pathway that goes to the pleasure centers of your brain, and it can be very tough to remove. But when you have a major mental illness, you put a substance of abuse in your body, and it forms a permanent neural pathway to the pleasure centers of your brain, the dopamine reactors, very quickly, within 3-4 doses. And there's even a couple of research studies, very competent research studies with robust results that said it was after 2 doses. So you're giving them an opioid, and their risk of addiction dependence is very elevated, which is not the same for people who only have a developmental disability and pain. So you add the psychiatric symptom, and it changes the picture, and that has to be kept in mind. So that's why we really don't want to go there unless we absolutely have to. If it was for a procedure, a surgical procedure, then the patient-controlled analgesia, is the PCA, is really not recommended for people who have a psychiatric symptomatology for exactly the same reason. The risk of dependence is high. Scheduled administration remains a priority in lieu of PRN, something that you can really keep in mind. The difficulties are the same. substance dependence, except it's much elevated. Substance dependence is probably 5 to 6 times more likely with people who have a psychiatric symptom on top of pain, on top of a developmental disability. All the other side effects are the same: constipation, respiratory depression, the potential for overdose, and tolerance that requires higher doses over time.
So there's nothing that we can do to guarantee that a person will not go on to develop a chronic pain syndrome if we have a developmentally disabled person that we're working with. However, there are things that we can do to minimize the risk that a chronic pain syndrome will develop. So let's say we have somebody that we're working with that has an acute pain issue. Maybe they've, heaven forbid, broken a bone or had some kind of contusion or a back problem. And here are some things that we can do to minimize the risk of that turning into a chronic pain issue. If pain medications are going to be used, if medically feasible, we'd like to schedule them regularly as opposed to PRN. And we have in the other workshops, and this one too a little bit mentioned, that PRN meds can be very problematic if they're PRN pain meds because they positively reinforce experience and complaints of pain. So regular schedule of analgesic meds is better if it can be managed medically. Treatment, I should say training on coping adaptively with pain should begin sooner rather than later. Unfortunately, sometimes we see that these kinds of interventions, cognitive behavioral skills as appropriate, relaxation training, distraction techniques, they're not thought of during an acute pain episode because we think that the person has a, quote, legitimate, unquote, reason for the pain, and then as the underlying physical problem heals, then automatically the pain complaints will go away. But as we've been saying in this and our prior two workshops, that isn't always the case, and sometimes acute pain can turn into chronic pain, unfortunately. And if we start the person sooner on learning skills to cope adaptively with pain, we lower the risk that they will then go on to develop a chronic pain syndrome. We don't eliminate the risk entirely, but we lower it. Many times, it's important for all of us who work with people in general and developmentally disabled people with chronic pain problems or pain problems, we have to check our own approach and check our own attitudes. It's very important to maintain a positive attitude, a visibly positive attitude about the person's ability to learn to be able to cope with pain adaptively. People are very responsive to staff expectations. If your approach or my approach to a developmentally disabled person is in pain is, well, they're always going to have this pain problem the same way, or it's kind of hopeless, or what can you do? You know, they only have limited skills to learn positive coping techniques for pain. People are going to live down to those expectations. So very important to monitor our own approach and attitudes, and at the same time maintain current knowledge of what is thought to be effective in terms of pain management interventions, so that we're practicing in as high quality and effective way as possible. And finally, as we've mentioned before, but it's important, so we'll mention it again, if we have somebody who's having an acute pain problem, we want to lower the risk of the development of a chronic pain syndrome. We'd like to positively reinforce all the competent coping that they may currently be doing with the acute pain problem. So make sure that we're interacting with the person when they appropriately report pain symptoms, but also when they're not focused on the pain, doing other things, provide plenty of input, opportunities for socialization, stimulation, interaction, and empathic support when they're coping competently with their acute pain, and that will help lower the risk of the development of a chronic pain syndrome.
The documentation of your pain management program is really taking credit for what you've done, what you're doing, and what your alternate plans are. And we've talked about having a plan, and then plan B and plan C, sometimes more than that. And you have to be fairly flexible. You can't be rigid about these things. You have to be conscientious and think carefully about all the components, and it can get quite complex. So you're going to be talking to your colleagues, and you're going to be coming up with a good pain management program, and you want to make sure that that's well documented so that everybody gets where we're going with this. So the effectiveness of the pain interventions, and I mean, you reassessed, you gave them something for the pain, some activity, some experience, some medication, some distraction, something happened when they had pain that you were aware of, or they complained of pain to you. And what did you do about that? And how did they feel later? Usually an hour that's the standard, and that is the standard by accrediting agencies, that you have a reassessment within an hour, but you don't have to wait an hour. You can, if you're seeing something happen within 15 minutes or 30 minutes, 35 minutes, that's what you need to write down, because it tells everybody else on the team, this person responds within that time frame. You don't have to wait until an hour has passed and then find out what's gone on. So and sometimes you see an immediate release. If they're distracted, then that's an immediate eventuality. So that's something you need to document. And what are your observations? How is the person talking about their pain? How are they expressing themselves verbally, non-verbally, behaviorally? What are you seeing about their psychological state, their emotional state? What are you observing about them in general? And these are extraordinarily useful points of view. And what does it mean? And we talked about your interpretations of pain and behavior, and interpretations can really set the stage for what's going to happen. What are your interpretations of what the person is doing? If you give them something to distract them from their pain, and they throw it off to the side, and they're very irritated about it, that doesn't mean that it's never okay to try to distract them from their pain. It just meant that that wasn't the moment for it. Then that's your interpretation of that behavior. That behavior is not they hate your guts and they never want you near them again, or that's a pain management technique that's just useless to them. Just that particular time it didn't work. And try it again. And if it happens again, then your interpretation can start to take on more meaning. That, this is twice it hasn't really worked for this individual. We need to take that off the list of options. And examples of an effective documentation of your pain management regimen is to write down how you assess. We talked about that during Module 2. Write down, what do you think is going to work for this individual? What have you seen work for the individual? How do they act when they are pulling themselves together around a pain management situation? How vigorous has everybody been in addressing this issue? Did it start fairly early, which would be ideal, is to have it, the pain management, like this fabulous Dr. Triggerbach mentioned, have it start as soon as possible. But sometimes there's a delay because you're dealing with so many other things, like the whole reason why they had pain to begin with. They might have just had surgery, and they might have had a major injury, and you're dealing with that kind of documentation. But when you document what you assessed, what it means, what you did, and how it worked, those main features covers your bases. And it allows you to take credit for everything you're doing, and it gives a map for everybody working with that individual now and in the future for how this can really be made to work. You're increasing the quality of that person's life. You're increasing the staff's understanding of this individual and how they work. You can find out a great deal just by those 4 steps. So that you write those down and you keep them updated, and that's going to be your effective documentation.
So many pain management interventions are not medical in nature. Many of them have an interactional or communication component. Or to put this another way, many times when we're trying to intervene in pain symptoms with people who have developmental disability, where it's going to involve us communicating with the person, interacting with the person. And it's always helpful to think about how we can adapt our communications to fit the person that we're working with. So patients do best when their communication preferences are taken into account. As we mentioned previously, for example, if we're working on skill building or skill acquisition, some people like to have a lot of back and forth, question and answer, more of a conversational or discussion format. Other people might like just to get the facts, just the facts, tell me what I'm supposed to do, that kind of approach. And we need to try to understand that about the person that we're working with and fit our communications to that preference. Some of the patient's preferences about communications about pain management and treatment in general are going to be the result of values that they may have learned long-term and maybe long ago as a part of their family of origin when they were growing up. And it's helpful, working in pain management to understand what some of those values are as well. So, for example, a person may have grown up in an environment where basically the approach to health was, if something is wrong, take a pill. And now they've grown into adulthood and they've kind of retained that value. They don't feel well, something hurts. Give me some medicine so I feel better. And you or I, as a staff member, we're going to approach this person and we're going to be trying to talk to them about skill building or other behavioral plans or comfort boxes, and their response may be, where's my pill? So an example of an ineffective thing to do or say in that circumstances is, you can't always take a pill. It's not time for your pill. We recommend that you don't say things like that. In part because it's at cross purposes with the person's value system, and so it's likely to produce nothing but trouble. What you might think of saying instead that might go along with the person's value system would be to say something like, well, this technique that we're going to learn, this may help your pill work better. So you're not arguing with their preference to take a pill, you're saying something in accordance with their value system. We also have examples of when the opposite extreme happens, when a person may grow up in a family environment where they are taught that all medications are bad. You never take the medications. It's chemical, I'm not taking it. I don't want any chemicals in my body. Putting aside the consideration for a minute that our entire universe, including everybody and everything in it, is made up of chemicals, whether you take pills or not. This is a value system that has to be, you have to be aware of this and respect this if your interventions are going to be as effective as they possibly could be. So in that case, you have to support the idea that the non-pharmacological intervention is the primary focus of what we're trying to do, and the pain medication, if one is prescribed, is just for a short term and may help all the other non-pharmacological and behavioral and skill building approaches that work better. So important to know who is the person with whom you are working, where are they coming from in terms of their values about pain, pain expression, pain treatment, and medical treatment. One time, the other extraordinarily excellent and awesome Dr. Triggerboff and I were at an American Psychological Association convention in Atlanta many years ago, and we rode in an elevator with B.F. Skinner, who is one of the founders of behaviorism. And he was in his 80s at the time, and we asked him, being the probing type people that we are.
And it was a long elevator ride.
And it was a long elevator ride. So, how are you feeling now that you're in your 80s? What's it like for you? And he said to us, well, the best thing that I can tell you is if you want to experience what it's like to be in your 80s is put on a pair of eyeglasses with something smeared on the lenses and thick gloves so it's hard to feel and manipulate things, and and you know, maybe a cotton ball in the mouth, so it's a little bit harder to talk, and then try to get through your day doing that. You'll experience something of what it's like to be in one's 80s. And we thought that was a very witty response to our question. But in the same vein, sometimes when we meet with each other, we have treatment planning meetings to talk about pain management interventions with people who are developmentally disabled. Sometimes it can be useful, as out there as this may sound, take a few minutes to practice communicating pain to each other, but without using facial expressions, or without using words, or not using congruent body language. Get some idea of what it feels like to try to communicate pain and problems with pain with some of the communicative disadvantages that some people who are developmentally disabled may have. And that can sensitize us and make us a little bit perhaps more effective in understanding these kinds of communications. It's also very useful to have case discussions. You know, pain management with a developmentally disabled person, whether or not they have coexistent psychiatric problems, very, very complex and difficult thing. It's not a routinized effort. Like, for example, if somebody has a bacterial infection, they take an antibiotic and that's the end of it. It's a pretty standard treatment. But in pain management, there aren't any automatically effective standard treatments. There are these combinations of interventions that come after complex assessments. And in formulating those assessments and treatment plans, you lower the odds that you'll miss something if you talk it over with other team members, other people on your team, particularly those who have some expertise and experience in working with developmentally disabled people that have pain problems. Get a wider selection of options that you can pick from. And sometimes it can help articulate problems that may be floating around in the back of your mind. You haven't quite gotten it into words, but something about the approach that we're taking or the plan that we're making doesn't quite seem right to you in discussion. That can come out, and often that can be helpful. And if the discussions are constructive and productive, they can help serve to energize the treatment team and keep us all working on pain management interventions, even in stubborn situations where there's treatment refractory or treatment-resistant chronic pain, or we're getting a lot of resistance. It's always good to get the support of one's coworkers, particularly those who know something about chronic pain management. So we encourage a lot of communication, case discussion, role-playing is appropriate, as well as reading in the field of pain management and taking workshops like this one, of course, to try to stay current and motivated in working with chronic pain.
Involving others in the whole communication process is vital. This is too difficult. It's too complex to do alone. You really need to talk to other people. You need to hear what other people have to say. Family members, friends, workshop colleagues, peers, other professionals. You need to hear what other people have to say, because the treatment, as wonderful Dr. Daniel Triggerboff said, is not rote. It is different for almost every individual. And every single time we've come up with a comprehensive plan for somebody, it's been because we have role-played, we have had case discussions, we've had, what did we figure out, like 2,000 cases we've consulted on. You know, we have thousands of options, and we didn't just come up with all of that on our own. We have brought in other people, and we respect the information that people have to give us, even if that information is shared in a, shall we say, ungracious way. You know, some people become very irritated because pain management, pain is so complex and the management of it is so hard that people become demoralized, they become irritable, they say things like, oh, nothing's going to work. And I can hear where that's coming from, but it still is giving me a lot of information, and we both have incorporated that into what we're taking away from the situation, that other people are frustrated. So that means this has not been an easy goal for them. They've tried these 6 things, none of them have worked. All right, now we need to look at 7 through 15, and we need to look at combining them in a different way. Another option that isn't used quite as often as we think it would be best to do is to take advantage of ethics committees and community involvement. Mental health associations, the National Alliance for the Mentally Ill, autism rights groups, advocacy groups, all of these clusters of people have a particular point of view. And it's not going to be 100% of what you need, because everybody's going to have their little niche of information that they're good at. That's where their expertise lies. But it can contribute something to what's going on, and it'll help you deal with a much more complicated situation than you might be prepared to deal with the information you have in your head right now. So listen to other people, even if they're communicating things in an ungracious or frustrated way. They still have something to offer you. And of course, relevant publications and peers can offer a great deal of information as well. The ultimate goal of the entire program that we've been talking about for these 3 modules is ongoing pain assessments. It's never stopped. You have somebody who's been in pain, you've assessed it, and you keep assessing it, and you keep assessing the management program that you've come up with. And ultimately, what we're trying to do is improve the quality of life for those individuals who have any kind of developmental disability and any kind of pain. That's where we're going with it. So we have some time to have some questions, but that you have for us. But these are the questions that we have for you, and there's 5 of them.
I can start?
You will.
Okay. Question 1, which of the following are pain management interventions that can be useful with developmentally disabled treatment recipients? Number 1, relaxation training. Number 2, prescription analgesics. Number 3, social interaction opportunities. Number 4, positive reinforcement of pain complaints. And the correct answer is C, 1, 2, and 3. Relaxation training is useful, prescription analgesics are useful, social interaction opportunities are useful. We know we don't want necessarily to reinforce positive reinforcement of pain complaints, so C, 1, 2, and 3 is the correct answer.
For question 2, when a developmentally disabled recipient is in pain, which of the following can be effective pain management techniques? Talking calmly to the recipient, offering empathic interventions, ignoring the pain symptoms to avoid positively reinforcing them, referring recipient to a prescriber for evaluation for analgesics and or other necessary pharmacologic interventions, 4, helping the recipient maintain relaxed, even breathing to avoid increased anxiety, which can in turn worsen pain situations. And the correct answer is D. 1, talking calmly. 3, referring them for evaluation, because evaluation for analgesics doesn't mean that they're necessarily going to get it. And 4, helping them maintain a relaxed, even breathing to avoid anxiety, and keep in mind that these things can make pain sensations worse.
Question 3. Throughout their lifespan, Down syndrome recipients, number 1, are likely to benefit from the same pain management interventions at all points when they are having pain symptoms. Number 2, may need pain management interventions that are less verbally oriented as they age due to the prevalence of early onset Alzheimer's dementia in this group of recipients. Number 3, are unlikely to need pain management interventions for gastric discomfort. Number 4, are unlikely to need prescribed analgesics for pain management at any point. And the correct answer is C, which is 2. They may need pain management interventions less verbally oriented as they age due to the prevalence of early onset Alzheimer's dementia in this group of recipients.
Question 4, you're working with an autistic female recipient. She's age 35. She appears increasingly sad and begins to complain of non-specific back pain. You should, 1, refer her for an evaluation of the pain symptoms only because it's likely her sadness is a result of the pain. 2, refer her for a psychiatric evaluation only because it's likely that the pain complaints are a consequence of her depression. 3, reassure her that soon she will feel better, as research shows that nonspecific pain and depression are transitory. And 4, refer her for evaluations for evaluations of her pain symptoms and of the depressive symptoms as they can interactively worsen over time? And the answer is A, which is number 4. We've talked about how depressive symptoms, pain symptoms, they become interactive.
Question 5, the most helpful and appropriate strategy for documenting pain management interventions includes, number 1, don't put too many notes into the record about such interventions because they tend to be repetitive. Number 2, remembering it is not necessary to document no change in symptoms because that would be obvious to the treatment team anyway. Number 3, using ratings from a pain symptom checklist as the only reliable and valid indicator of progress in treatment. Number 4, using all sources of information about the effectiveness of the pain management intervention strategies and documenting frequently and extensively so that anyone reading the record will understand how the recipient is responding to the pain management interventions. And the correct answer is, of course, D, 4, use all the information, document frequently and extensively and competently.
So there's going to be a survey that should pop up on your internet browser if it hasn't already. If you don't see it, then tomorrow you'll be sent an email with a link in it, and you just follow that and then proceed. And if you have any questions or comments, I mean, we have some questions for us about the content, but any other questions or comments, that's when Lisa does her stuff, and that's how you get a hold of Lisa. So Lisa's going to check and see if anybody has any questions.
I'll let you know that
We do have a raised hand from Leslie C.
What can I do?
Leslie, I've unmuted you, so if you do have a question, go ahead and ask her now. Leslie?
We tried.